Okay, I think there's a couple more advisory council members who might be joining, but it's a couple minutes past 2:30. So why don't I go ahead and I'll get us started, and Katie can help out with having others join. First of all, just wanted to say a thank you to Katie, who is in the meeting room, since I was nervous about spreading the word to all potential attendees, that I was going to be virtual and others would be. So Katie's holding down the fort. Much appreciated, in case anyone arrives in person. And thanks all for the kind of change in scheduling and accommodating me needing to work from home today. Much appreciated. Really glad that we could keep the meeting on the calendar. I think it's a shorter agenda, but some important discussion, especially towards the end, about some of the thinking that I kind of previewed or teed up about policy at the beginning of during our last meeting. Briefly, before I open up the slides and we get into that, I had one small housekeeping sort of item that I just wanted to share with the group. I can't believe it, but we are getting pretty close to the end of this calendar year, and realized needed to start thinking about a schedule for meetings for 2025. My proposal was that it seems like this time works pretty well for folks. I think we've had pretty consistent attendance, and there was nobody for whom this time was a challenge, I think, when we solicited feedback. So I'd like to propose moving forward with just staying on the same schedule of the afternoon of the first Wednesday every other month. So we'd start in February, like we did last year, following our December meeting at the end of this year. Welcome if there's feedback on that, either raising a hand now or maybe let both Trevor and myself know after this meeting, and we can put heads together if there's a need to revisit. But if I don't hear more in the next few days, my plan will be to just get calendar invites out for that and kind of set up the meeting schedule for 2025. Amazingly, it's incredible that we're there. So apologies for not popping that on the official agenda. It had been on my mind, and just didn't include that, but wanted to touch on it before we are in the last month of the year. So with that, I'm going to go ahead and I'll open up the slide deck that I shared for this meeting. Is that showing up okay for everyone? Great. And I'm just going to try and make all of you a little bit bigger for me. There we go. So moving right into our agenda for the meeting. I can make my buttons work. You can tell how unused to it I am, working from my little screen at home instead of being in the room. Give me 1 second. There we go. So the agenda for the day is, really sorry, bear with me. There we go. Just a brief update on the annual public hearing that we had that was just 1 week ago today. Little different than last year where we had a full readout. The time was just really short between that meeting. We're actually still accepting written comments, so I won't do kind of a full debrief from the public hearing, but wanted to share a quick update. We're talking about facility fee report planning. That's something that I've touched on in a couple meetings in terms of thinking about the legislative session and some of what's on the office's plate, but again, wanted to give a little bit more of a substantive update on what we're thinking about for that report, and especially get some feedback on some early kind of decisions about the structure and approach there. And finally, revisiting the policy domains that I had previewed during our August meeting, where we just kind of walked through them and how I had thought about organizing them, to have more of a discussion. And I've done a little bit of work about thinking about how to kind of assess those policy domains and think about where there is opportunity and a role for the office, and where we might want to focus a little bit more on discussing policy concepts and ideas within those domains. That's the agenda for today. So on to the update from the public hearing. As I said, 1 week ago today, the afternoon of the 25th, I think we had a good showing. We had about 10 people testify in person or virtually at the hearing. As I mentioned, we are still accepting written testimony. And last time I looked, we had more than 20 submissions of written testimony already. So pretty good representation there. I think we're on track to meet and hopefully exceed by a little bit the number of comments that we received from last year. That comment is being accepted through this Friday, and information about how to submit that, as well as a recording of the public hearing and the slides that we used, are all on the website now. We did updates pretty quickly to that public hearing page to get the information up. So if folks weren't able to make it and you're interested to see the presentation that we gave or hear some of the public comment, you can do all of that now. The other quick thing I wanted to touch on as it relates to the public hearing is that in thinking about soliciting input and soliciting especially thoughts and sort of feedback and experiences from members of the public, from patients, consumers, we want to definitely try to do that through the formal public hearing process, but I've also been wanting to think about other ways to reach out and hear from those individuals in a format that might be a little bit more accessible for them. I know it can be hard and intimidating to sort of write comments and come and deliver them. So we've been lucky. We're working with a national organization, United States of Care, that's been able to come in and help support us to plan some additional kind of supplementary listening sessions that are focused just on consumers. I say listening sessions, but it's really more a structure like a focus group, but just not as formal as a focus group, in the sense that we're not sort of using a totally randomized sample to reach people and invite them. We're trying to work with community organizations and legislators in certain areas to invite people to those sessions. And there'll be more a sort of a discussion format. So some prompting questions and chatting with people. So a way to kind of reach people who may not have, that one issue that they've already been activated on, but given that the office is charged with understanding barriers to healthcare that are based on affordability, wanted to try and do a little bit more there. So planning some sessions that are going to be in late October in the Portland area, Lewiston and Auburn area, and then up in Machias. We wanted to kind of do some geographic diversity there, and working in particular with Trevor and some others to think about bringing some businesses together so that we can hear business perspectives, but then a couple of the sessions also being focused on individual consumers. So I'll pause there if there's either questions about the hearing or about those listening sessions. Okay, great. And as I said, I think for the December meeting, when we've had a chance to collect and review all of the written comments, I'll try and do something similar to what I did last year, where we kind of summarize in the same way that we plan to the annual report, the comments that we heard and some of the takeaways. So moving on, I wanted to talk, as I said, about the facility fee report request that we received from the legislature. This came in the form of a letter from the HCIFS committee addressed both to OAHC and MHDO jointly. Just as a reminder for folks, I know some of you are following it really closely in the legislature, but others likely were not. There was legislation considered in kind of both sessions of this past legislature. In the first, there was a decision to create a task force to look at facility fees that met on a really condensed schedule just a few times towards the end of the year. Last year in 2023, the office was represented on that. I represented the office, but not a non-voting member. And that task force came out with a few recommendations, but I think folks on it felt probably like there was more conversation to be had and work to be done to kind of understand the issue. And then finally, the legislature in this past session, or the HCIFS committee, passed a bill with some transparency, some sort of notice requirements related to facility fees, but then came to MHDO and to our office and asked us to study the issue a little bit more and to come back to them with information and some analysis of what's happening in other states and recommendations. So I included the sort of request language here on the slides just so folks could see that specifically and understand that this is the ask that we in the office are responding to in this report that we're envisioning. I wanted to talk briefly about the report structure, and this really comes to some extent from my experience on the task force. I know I at times felt like when we were having the conversation about facility fees, we were bouncing around between trying to define what we meant when we used the term facility fee, talking about solutions, coming back to definitions, then going to consumer challenges. And that was one of the really tough things about trying to sort of move the conversation forward and make progress, was sort of a lack, I think, of a structured way of kind of talking through these issues and building on each other. So that's part of what I'd like to do in this report. And to me, what felt most important as a starting point was to develop a clear and a practical definition of a facility fee. And what I mean by practical is we did see some examples from other states that used language that sort of would say, a fee intended to reimburse a hospital or facility rather than to reimburse a professional, which I think is helpful, but definitely in conversation with others and from our own work in the office, there was still a challenge in translating that to for example, a data application and saying, okay, but there are modifiers to certain codes on professional fees that do actually account for other professionals or sort of analyst services or supplies, and are we including that? So we wanted to come up with a definition that we actually felt like in practice we could sort of work with. And then I also wanted to note in this definition, I think another challenge is because the conversation began at a place of kind of legislative intervention, the automatic assumption that a facility fee is a bad thing. I think we want to note that a facility fee and reimbursing facilities for expenses to care for patients, particularly in high intensity needs or with 24-hour availability, is important and necessary and expected. So would just note that those are sort of the two considerations that we're thinking of in developing a definition, but that's sort of the first thing that we need to do before we can probably make much progress or very effectively take on the conversation about how does this impact patients and what should be done. So from there, we do want to assess the impact on patients. I think thinking about affordability and transparency concerns, both, is it affecting price, but also is it affecting sort of or confusing patients or creating an unexpected expense, even if the total expense doesn't change, kind of think about those two dimensions of consumer impact. And really in this section, I think hoping to be helpful in differentiating what this looks like depending on the coverage type that people have. That was another place that I think the conversation got challenging in that tight, condensed task force group, was what this means in like the Medicare context is very, very different than in commercial coverage. So acknowledging that and making sure, I think in the discussion of patient impact, we're going to try and really separate this out and talk about coverage groups specifically and how patients are impacted differentially there. And then finally, based on that assessment of impact, I think that's where we say, is there a need for additional, legislation or policy change here, whether that be clarification of current policy or further policy based on what we assess as consumer impacts or challenges, and then making some recommendations from there. So just kind of wanted to preview that. I know, again, that maybe seems straightforward or expected, but it really felt important to me, again, in this context, because I do think that that's a lot of where the kind of spinning of wheels seem to kind of come from during the legislative process, at least just from my perspective. So to move on, one place I wanted to sort of touch on with this group and get some initial feedback or reactions, if folks do have it, is on the issue of defining facility fee. This is something that Katie from the team and I spent a lot of time looking at. And I will just say really candidly, it's an unusual scenario. I think both of us pride ourselves on being good researchers, that there actually isn't as well understood, I don't think, really consistent definition for this term. It does seem like states are doing slightly different things in terms of how they're defining it, again, both maybe in a policy context and then more practical application in terms of data reporting, collection and reporting that they're doing. So there wasn't an easy place to go and say, just like, this is the accepted definition, we just need to make people aware of it. That being said, I think that from our own kind of research and discussion, that the most basic, simple structure for talking about this is to kind of define facility fee as any services that are billed on the UB04 claim form, that institutional claim form that's differentiated from the CMS 1500 form that's used to bill for professional claims. Katie, I see you have a question or comment, so I'll pause there.
Thanks. I just want to be clear. So you're saying that the definition that was passed by the legislature, you're going to suggest a different definition than that which was passed by the legislature?
I think it's worth exploring. I welcome your thoughts. I think my concern is whether, because I think the legislative language that was passed for the notice requirement is sort of following that structure of a charge for that goes to support the facility as opposed to professional claims. Am I wrong about that, Katie?
No, I think that's correct.
Okay.
I think that's correct.
I think my concern with that is, at least in the task force conversations, when we were trying to talk about what that meant from like a data reporting perspective, that folks, including I'll say, you know, Jeff and some folks on the hospital side, like it didn't seem like there was a clear connection between that terminology and and claims or any structure that would allow us to say, like, in a practical sense, like this is or this is not. I think definitely if there's been work around that since the notice requirement passed, you know, would be happy to kind of take that in. And that's sort of why I wanted to preview this, was to get others' thoughts, because if there is a sort of more operational definition that we should think about or stick to, welcome trying to use that.
I think it's fair to say, and I'm not sure why my camera's not working. Sorry about that.
Oh, we
but
can see you. I can see you at
oh,
least.
oh, okay. That the definition, so as I recall, we talked a lot about the definition in committee during the second session after your task force presented its report. And I think we amended the definition, not to say that it's not worth revisiting. I understand what you're saying as it relates to reporting, but Karen Lee would definitely be, I encourage you to confer with her, because she was able to pull the data related to facility fees without any problem, it appeared. So maybe just conferring with her in terms of how she defined it.
Yeah, and I will say we have looked through the report and had some conversations with Karen Lee and the MHDO team about this. And I think that her analysis follows essentially this definition that they separated out and were reporting essentially on UB04 claims as opposed to CMS 1500 claims.
Sounds good. All right. Thank you.
Oh, yeah. I will say, you know, one thing we're thinking a little bit about is, you know, more nuance there in terms of understanding, like, when are both being billed for the same service and things. But yeah, I don't think that this is inconsistent or takes a different track from how MHDO has been thinking about this issue and approaching the analysis. And I will just add, just to sort of finish out thoughts on this slide, you know, a little bit more of our background thinking. And I do appreciate you flagging that, Katie, just to make sure that we don't create an inconsistency with the more recent Maine law. I will say I was thinking a lot about the prior Maine law that we talked about a fair amount in the task force from early 2000s, when this issue had come up, and sort of keeping consistency with that law. But we also wanted to think about, you know, what's a definition that we felt like captured the types of scenarios that consumer advocates and some of the policymakers that had initially brought this issue up were thinking about. And we felt like this captures that. You know, I don't think they're concerned about modifiers to 1500 claims. So this felt like the right definition to capture any genuine challenges that consumers are facing. And again, just that translational piece of really wanting something that we could get into the level of detail that we needed to kind of move the ball forward on the conversation, is the other reason we wanted to be kind of this precise. I'll pause there just in case anyone else has thoughts on this. As usual, you know, it doesn't need to be the end of the conversation. Welcome if anyone or their teams are thinking about this and want to talk more or share follow-up afterwards. But any other initial reactions? Great. So then moving on, as I mentioned, something that had been top of mind for me, because it did feel important in the context of thinking about how are things working now for consumers, and you know, if there are gaps, what are they? The existing Maine law on this, and it's not the only one. There are some other existing Maine laws that touch on facility fees, some from the notice component. All of that is in the task force report. But I thought that this was some of the kind of stronger language, and this really actually sets Maine apart from a lot of other states. That we have a law requiring that claims for services provided by a healthcare practitioner in an office setting be submitted on the CMS 1500 form, which is the form for non-institutional provider. So essentially saying providers should not be using that UB04 form to bill for claims for services that were provided in an office setting. And there's a requirement that insurers not accept, or they're not required to accept a claim that's submitted on a UB04. And there's some language defining an office setting here too, fairly high level. And I think part of the reason that this was top of mind for me was looking at the MHDO report, that it did seem like there is some lack of consistency maybe across sort of both across providers and across carriers in terms of how they're interpreting and operationalizing this language. So if you look at that report, there are some services that seem likely to be in an office setting where you're still seeing a fairly significant number of claims that are being billed on a UBO4 form. And that's where, understanding why that is and digging in a little bit more, it's helpful to have these clear definitions that allow us to do that. And likewise, I will say, I think it seemed like kind of across the board, there were some themes and carriers with a few maybe being outliers and where it seemed like they were paying claims much more frequently on a UBO4 for certain services or a range of services, whereas others were not. And I think that's just really helpful to understand. I think a lot of the questions in the task force and in the legislature were, okay, if this, language stands, then why are there, some consumer concerns, or why are there stories that we're hearing reported? I think there's still questions about that. In some cases it might be a mistaken bill, but it may be that part of the answer to that question is if there's not a consistent understanding of what this law means and how it should be implemented, that could be creating some of the confusion or a segment of kind of consumer experiences that might be problematic in this space. So that's one thing that we will be thinking about, leads me to our next steps for this project. So one really big one that I wanted to just kind of preview with the group, we created a kind of set of questions, both for providers and for carriers, to try to ask some questions about sort of, again, how they understand and define and operationalize that language that's in existing Maine law. I think when we had opportunities to engage in the task force setting, one of the things we heard was like, it's a little hard to maybe share policies or information about some of this in a totally public forum. So we thought it might be helpful to kind of do this questionnaire process, send it out to folks. We can kind of keep answers de-identified and just report at a general sort of high level of, yes, there seems to be consistency on this point, or on this point, some folks are doing it this way and some folks are doing it a different way. Again, to just kind of pull back the curtain and get a better sense of where there's opportunity, again, maybe not even for a law change, but just to kind of say there should be a more consistency in doing this the same way across the board. So hoping to approach the Maine Hospital Association and Maine Association of Health Plans, that have been my thought for just sharing that out with their members potentially as a way to gain some more clarity and kind of get a on the ground perspective on some of this. Additionally, as I mentioned, we talked with MHDO a lot. I think Karen Lee might be on right now, I realized, and want to continue engaging with them and talking about the analysis, getting questions answered and thinking about, are there adjustments or different ways of looking at that data that can be helpful to the legislature. I will just say I think the report itself was super helpful. If folks haven't seen, there's the written report, but then there's also some additional data tables with much more detailed information that Katie and I were able to dig into that were really informative and helpful to us on this issue. And then, of course, just to make sure we're being fully responsive to the language from the statute, reviewing and summarizing the approaches of other states. I will say, I think knowing that we have some language and already kind of have a structure for this in the state, I want to be mindful about not then trying to add in sort of a different approach or different definition that's pulled from another state, but do want to do kind of a comprehensive review for everyone in a summary and think about if there's learning from other states that we could potentially incorporate in as we assess the impacts and then think about the policy component. Any other thoughts or feedback? This is sort of the end of the facility fee portion. I saw Dan said he would be happy to help, so appreciate that very much, Dan, on the carrier side. Any other comments, concerns? Yep, Katie.
Sorry, just one more question. As it relates to sort of looking at facility fees, I mean, I'm struggling because I think Karen Lee did a pretty comprehensive review of the facility fees. So it sounds like you're going to take that one step further. And it also sounds like you're incorporating Medicare into this analysis. And it goes back, I think, to a conversation we had a year ago or so related to, is this group is the Office of Affordability really specific to commercial, trying to improve the affordability for commercial payers and commercial patients, or is it comprehensive, in which case, I guess if it's more comprehensive than that, then we really need to, I guess, really need to understand how we're going to grapple with the broader complexities related to Medicare and Medicaid, which are paid very differently, and they're not really technically insurance. They're payment, they're payment plans.
Yep. So to start with the question about MHDO, I would say totally agree with you. I think it was a very helpful data analysis, and we're not looking to duplicate that or do data analysis of our own. I think it is more of a qualitative review, because I think what Karen Lee can look at is to say, okay, for a service, this payer paid this many claims on UB04 and this many on a CMS 1500, and this payer paid a really different ratio of those claims on the different forms, but can't say, like why that might be, or, I don't think it's necessarily MHDO's role to kind of opine on whether that is consistent with the current law or whether there are impacts on patients that can be changed. I think that's a data analysis foundation that we can then build to answer the question that we got from the HCIFS committee, which was more of like a policy oriented one. So yeah, I don't think it's duplicative at all. I think it is taking it that next step, because I think if they looked at it, the report, which hopefully members of the committee did, they might ask some of the same questions I did of sort of, well, why is there that variation? And do we all agree that that service is likely provided in an office setting, or is there something where the setting that it's being provided in for this carrier is influencing the percent that they're paying on the UB04? It's really more not redoing data, but answering questions that the data raises, I guess is what I'd say. And then on your question about the Medicare piece, it is helpful to differentiate. I think we need to speak to the experience of Medicare enrollees, because so many of the individual stories or the contacts, I think, from constituents to legislators were individuals who were enrolled in Medicare. So I don't think we can just totally ignore that and only talk about commercial. I think it's important in the report back to talk about why that experience is different, and isn't, that we can't address it in the same way that maybe an issue for a commercially insured individual is something that the legislature can. So I guess I would differentiate describing that, explaining it for legislators so that they have that information in that context as they're understanding maybe inputs that they get from constituents or from others, versus making policy recommendations. Because I agree, I'm not looking, Medicare is doing plenty of their own work in this space. I don't think the state has the authority or wants to begin to dabble in that. So it's more about, laying that groundwork and making that clear and explaining why to legislators, rather than that being within the scope of policy recommendations. Does that answer your question?
It does. Thank you very much.
Great. So moving along, I wanted to revisit, as I said, kind of the planning and policy development conversation that we started at the last meeting by just running through some policy domains that I had put together. To start us off, thought I would just pull back up, though I won't read through them again, but as a reminder, this policy development charge language that the office has around improving cost-efficient provision, coordination, quality of the healthcare system, and then affordability for individuals and small businesses. And then briefly, I'll just walk through the domains again. I did in an appendix to these slides, I included all of the kind of summaries and the coverage in other states, or the summary of what was happening in other states for everyone. So everyone has those slides if you want to revisit and refresh memory, or for folks who weren't able to join us last time. But just briefly, I kind of, in an effort, as I said at the last meeting, to bring some kind of order to such a broad charge and question that we're grappling with, of kind of where should the office focus, what's the what are the areas of opportunity, had kind of organized a lot of the ideas that we'd heard about from other states and from other presenters or that folks have raised in the meetings into some kind of categories. So summarize those as subsidizing consumer costs, constraining prices, aligning incentives for efficiency, insurance market oversight, provider market oversight, and then prescription drug affordability, which, as I noted last time, I kind of put on its own a little just because I think it's a bit of a standalone item that doesn't have quite as much intersection with some of the other issues. And what I wanted to run through today and then definitely open it up and have hopefully some good discussion on this is the way that I was trying to assess the kind of promise or the opportunity within these policy domains for the office. Again, recognizing that this is inherently sort of like a messy process and requires some generalizations because we can't get into the weeds of every single policy and its merits or challenges without doing everything all at once. So again, this is high level, but I think hopefully is a way to move us to a place where we can get deep in the weeds, but on a manageable set of policies instead of everything under the sun. I saw Katie's note on another domain being workforce and labor, I think. Just pulling it up. So that's a good note, Katie. Yeah, happy to consider adding that in. I think I was trying to focus on where we can create a direct connection to consumer affordability and some of those goals, but definitely hear you on, efficiency, coordination, that being a challenge. So I'm glad to give that some more thought. For the domains that I do have, the way that I was thinking about, again, evaluating them, I guess, or prioritizing is through sort of three dimensions. The first I called alignment, which really for me was about how well does the domain align with the office's statute and also the guiding principles, kind of the two things that we thought about in terms of guiding where the office should focus policy attention. Feasibility felt like a really important domain. It connects because I think feasibility is sort of included in the guiding principles, but I wanted to call it out individually. I've always said that it's really important to me to look at policies that feel achievable. So tried to think about operational constraints, legal constraints, and then just kind of the context that we are all existing in, politically and otherwise, to think about feasibility of policy ideas. And then finally, opportunity. I admittedly struggled with the right word to capture this, so there may be a better one. But an extra component that I try to think about is what sort of the office's role within state government more broadly. Where are there places where the office is really kind of like uniquely positioned to address something where other state agencies aren't already active or maybe don't already have authority. And that felt like an additional kind of helpful way to just begin to narrow in or think about how the office can be most impactful. I should pause there. Any comments on kind of that way of assessing, I guess, policies, anything that anyone would call out as missing there before I move on to talking about how I try to apply that to the 6 domains? Great, can always come back. So moving on to this assessment, I tried to make it a little bit more digestible by using this kind of color coding where I used, I'm sorry, I didn't think to put a key on here, but green to sort of say good alignment, sort of, positive association within that dimension that I was assessing it under, the kind of orange color for a little bit in between, and then red where it felt like there's maybe a disconnect here or not necessarily a good fit with what I was thinking about in terms of alignment, feasibility, opportunity. So I thought I'd maybe just kind of go through these domain by domain and kind of go through my assessment and then just have a pause for others' thoughts or questions. So starting with subsidizing consumer costs, I put this in kind of that medium category for alignment, acknowledging I think it's a high opportunity for relief for a segment of consumers generally, which is of course important in terms of that affordability component of the office's charge. But doesn't address kind of underlying costs or efficiency or make systemic change. A little bit is a bit of a cost shift, really, even from consumers to generally the government, which can function as a shifting between consumer groups. So there's definitely positives to this, but that was one drawback that I thought was important to note. I also should have said at the top, I just want to make clear, this is me thinking about like this moment in time for this office. It's definitely not meant to be a comment on these policy ideas generally or in other contexts for other agencies or states or in the future. It's really just about in the short term, again, trying to narrow down and bring some focus to the office. So just want to say that out loud. I think there's lots of good work in many of these spaces being undertaken by folks in Maine and out of Maine. And it's not a comment on that, but more the office's specific role. So moving on from alignment to feasibility, I think this came up briefly in the conversation at the last meeting when I had mentioned the subsidization of consumer costs, and Jenny Boyden from DAS, had commented on challenges in terms of budget. I do think that identifying revenue for subsidies or expansions of coverage types is a significant challenge. The states that we heard from had raised new revenue for this. And while I don't think that's impossible by any means, I think that's difficult and worth noting as a tough road for this type of policy intervention. And then finally on opportunity, I went back and forth. I think this, could be a green, but I kind of wanted to note that definitely it's a place where there would need to presumably be a lot of collaboration with other agencies, that being maybe the Bureau of Insurance, the health insurance marketplace, our Medicaid program, regarding both like the coverage options related to this, and then certainly, working to raise revenue is a complex and multi-stakeholder sort of consideration as well, that would not be something kind of clearly just within the purview of the office. Pause there and see if anyone has thoughts or disagrees with any of that, would add anything. Again, acknowledging I tried to do this in a way that was brief and concise to kind of fit on and work in organization for the slide. Okay, I'll move on for now to constraining prices then. For alignment, I gave this one kind of the green rating based on the fact that I think there's opportunity for broad impact here across markets, and also potential to kind of redirect resources for greater efficiency. The idea being, if you're thinking about kind of outlier costs, that there's some ability to constrain on one side and therefore be able to invest more or in maybe upstream types of care. And that felt like a good sort of point of alignment, I think, with the office's mission and the guiding principles. For feasibility, I did an orange here. I think understanding that they're trying to achieve savings here from constraining prices has to consider whether there's opportunity to do that without impacting access to care and quality of care, which is definitely a challenge. That's not a straightforward proposition. And finally, for opportunity, I did rate this one as a green. It didn't seem to me, from my knowledge, to be a place where there is a current state agency that sort of thinks about this or is working on these issues. So saw that as a place where it would be, a addition for the office to be involved or to be examining or thinking about policy in this space. I just saw Kevin had a comment. Where would I fit evaluation of expanding the small group market up to 100 employees? I would put that into insurance market oversight, Kevin, in terms of the policy domains. Helpful. Any other comments on constraining prices? Keep on moving along. So aligning incentives. Oh,
Meg,
yeah.
I would just note, as you said, it's important to constrain prices in some areas, but there are other areas where we may want to invest more. So I'd say it's more about realigning prices to invest in the services we know where there's high value.
Mm-hmm. Yep, that's helpful. Katie?
Thank you. Sorry, I'm trying to be quiet from here, but I agree with
please.
Trevor.
I want discussion, so I welcome it.
I agree with Trevor, and I would ask, so what prices are you defining prices here? Is it the prices that patients are paying? Is it the prices that, because I think I've heard you say that you're not talking about the prices for insurance. You're not talking about premiums. I think it's important to be clear. Are we talking about what consumers are paying? Are we talking about something different than that?
Yeah, that's a fair point. Probably clearer title is constraining provider prices, because I do think that was the focus of the policies that I'd categorized into this group that we went through last time. So really mainly that was, I think, the cost growth targets that some other states have done, some of the state employee plans that have set benchmark cap prices for their state employee health plans, and then the public option plans that in a few cases have either said, we'll come in and cap the prices that the insurer and patient together pay to the provider, or set sort of like an aggregate cap on those. So that's the categorization here, is provider prices, though I do really appreciate Trevor's suggestion, and so can maybe retitle this as realigning provider prices, more about, do we want to think about outliers on one side and outliers on another, and sort of trying to pay less maybe for some services that are currently really high priced, and pay more for some that we think may be underinvested in.
And I guess I that makes sense to me. And I guess I would suggest from my perspective that there's no reason that the Office of Affordability, since our focus is on the commercially insured or privately insured individuals, I would think it important for us to feel comfortable making recommendations as it relates to the private market, the insurance market as well. So I'm not sure I would necessarily put it in red if we see an opportunity there. I wouldn't, because it all fits together and it's hard to segment it out.
Yep. Happy. Why don't I just go to insurance market oversight, and then we can incorporate that, and then I'll come back to the aligning incentives one. So for insurance market oversight, I did use that middle kind of assessment for alignment. Went back and forth definitely on this one, but ultimately I included that only because of the limits on federal preemption, meaning that sort of the reach of insurance oversight tends to only reach, a segment of the commercially insured market, and see that as a little bit of a downside, or just a limitation that I wanted to consider. For feasibility, and this was also a very tough one because there was a wide range of policies in this area, but I felt like it was worth rating it as green because it is sort of a well-established structure for state authority. Though I did also note an area where there's been quite a bit of change and development and some policy movement over the last few years, which kind of factored into the decision, but decided to keep that as green. And then to your point, Katie, I did rank this one as red on opportunity, and that wasn't to say that the office can't or doesn't have a role here. All I was trying to represent in this column was just the feeling that we have a Bureau of Insurance that is focused in this area. So, I mean, I do engage with them quite a lot and welcome, going back and forth and sharing ideas. But the feeling that, there's a channel to sort of bring ideas to them directly that folks have, whereas, what are we adding in terms of expertise or perspective? And that doesn't need to be a final decision. Definitely hear you. And again, it also doesn't close the door on either the office or the advisory council having thoughts on that, including, maybe Kevin's about expanding the size of that market, but sort of, is that something where the office can really create a new opportunity in the state, or think about something where there isn't kind of a home for policy now, which is all that I was trying to represent there. Great. To loop back to aligning incentives for efficiency, I was kind of excited about this one to rate it all as green. And this was the category really about thinking about new payment models and innovating in that sense, where we thought about, again, just not the only one, but global budget models in other states, or primary care payment models. Definitely saw really great alignment here in terms of the office's mission and guiding principles. In theory, it can be really a win-win in terms of efficiency and quality and cost for patients and the system as a whole. So saw a lot of promise there. I also rated feasibility here as green, just coming from the perspective that I think this is an area where there's already good work happening there that can be built upon, and where generally like there can be a lot of alignment in goals. The challenge could be how to accomplish them, but it's not, maybe such a big political challenge or the challenges that some of these other policies face from legal constraints or others. And then finally, in terms of opportunity, very much acknowledge that there are agencies in the state with more expertise here, particularly I'd say, the Maine Care program. But this idea kind of excited me because I do think it's a place where maybe there's potential for, multi-stakeholder convenings and thinking more about like what from the Medicaid world could be transferable into the commercial world, or where there are opportunities where if we can kind of promote or align around a good model that folks believe in, where we can actually grow that to a scale where it can be really impactful, and kind of inspired by, I think, some other states that were able to come up with tables and sort of develop their own models and even go to CMS with those ideas and find ways to work with the Innovation Center to implement them was something I was, just excited about the concept of and saw as maybe a good role for the office. Sorry, Jeff, I thought I'd just finish out the line, but would love to hear your thoughts on that.
No, that's perfect. This is an area that I've done, a fair amount of work in, and I think same with, Maine Health and Northern Light Health and a variety of models that we've worked in. But I think you're overestimating the feasibility significantly. And I'll give you a really good example. There's a good model that we liked a lot. We still like it a lot. Primary care. It's supposed to be, a multi-payer model, and there are no other payers other than Medicare in this model. And this is created, it sort of exacerbates, what we call the two canoe model, right? So we got one foot in fee for service and we got another foot in a value-based care model. And until you get enough, lives that you sort of can fully step into that other canoe, then it just becomes sort of an administrative hassle. So I think the feasibility, I love this area, don't get me wrong, but the feasibility of doing something on a collective basis, I just don't think is there. And what we see from most commercial payers, I'm not putting Kevin in this because he's not a national organization, but the nationals want to use their model, period. They want to take their boilerplate template model, and that's the model that they want to use. They don't even want to hear any moving off that particular approach. So as much as I love this area, I think it is nicely aligned. I think there's significant opportunity. I think it's a boatload of work.
There, and to be clear, I also, in terms of feasibility, definitely don't mean to imply that any of these are easy to begin with. I was going to ask Jeff, just to kind of like take that a step further. Is it a place where you think it's hard but worth exploring and worth talking about, what this could look like? Or, do you kind of feel like, listen, not worth the time, too big a challenge? I guess taking in your comments, I would love to hear others, but
I think it's worth the time and effort, right? Because we're as a healthcare organization, we're trying to be super efficient, right? But if we have 8 different value-based care models, that focus on different things and different approaches, that's just not going to work well from a provider standpoint, right? They have to say, oh, well, this is an Aetna patient, and they're in this program, or they're an Anthem patient or in this program. They don't have to be perfectly equal, but they have to be very, very well aligned. And right now we're just sort of not seeing this. And we really liked the primary care first model. We're in our 4th year of it. It's got one more year to go. And we like the approach that CMS took for this. But nobody has joined the bandwagon. And so it's almost like it's like the redheaded stepchild right now of value-based care. If we had gotten, one or two large commercials to join, or if, Maine Care had moved along more quickly, I know they want to do something, and they're moving down that path, but the path is probably going to come to an end here before that actually happens. So I mean, I think getting, alignment across the stakeholders is worth the effort, but it's going to be a big climb.
Yeah, hear ya. I guess the one thing I will say is I don't know that the goal has to be complete alignment. I think creating a space for some conversation and planning outside of like individual opportunities just seems to me like it could be worth the time and effort. Again, this is, just from my experience on the outside, but at least looking in, it just so often feels like all of a sudden there's an opportunity and you have such a quick amount of time to decide in or out, and the rules are already written. Just the idea of sort of trying to take a step back and do some work collectively, even if it is only a component of commercial, but bringing a few folks on board and having maybe a little bit more of a unified perspective, so that it doesn't always feel like it needs to be so kind of like reactive to CMS, acknowledging that the feds have such an important role in this. And certainly, I think depending on, what happens next month, they may influence things kind of one way or another, but especially if they, decide to be more aggressive in their own kind of leadership in one direction or another, kind of being prepared and feeling like we're as ready as we can be kind of collectively as a state to take advantage of opportunities. Is just something that, again, I feel like worth the conversation about how we might do that, and an area of interest and kind of passion for me too. So, but definitely appreciate your comments, and I will downgrade this to an orange, definitely in recognition of that. Just recognizing Katie agreed as well, and Renee's comment, what a challenge it is to do background work when the plans have different rules for different payment models. So heard and understood. I wanted to come in with one that was all green, but we can be realistic here for sure. Any other comments on the aligning incentives for efficiency domain? Okay, moving on to provider
Can I just
market.
say, Meg,
go ahead.
I do
Yep.
think that uh, focusing on efficiency, despite it being incredibly difficult work, is really worthwhile work. I mean, we know that that many provider organizations are struggling financially, but prices continue to be a huge issue for purchasers and consumers. And when you have these two competing situations, really you're only left with so many options, and efficiency strikes me as one of the most realistic. So I get what Jeff's saying totally. I think that's a huge issue, but maybe there are other areas we can get at improving efficiency beyond these payer models as well.
Yeah, that's a good point too. I guess within this category, based on just not what's going on in other states and what I was trying to capture, really focused on specifically different payment models, but there could be, a more expansive understanding of what this means, maybe some more creative thinking too. So the second to last category that I heard here was provider market oversight. This one, again, I struggled a little because it did have some different types of policies in it, from sort of the more comprehensive oversight programs, like the healthcare market oversight program in Oregon, to some of the work that states more recently have been doing or looking at least around kind of private equity acquisition of hospitals. And so it was one of the categories I found harder to kind of summarize for alignment. But why I chose green and what I wanted to represent was particularly, I saw some high alignment in thinking about how to protect against financialization of healthcare providers. And I use this term, I just heard it in a presentation recently, that rather than sort of saying specifically private equity, just some of the behavior and to be really frank, what I am thinking about in part is the situation that happened with Steward Healthcare down in Massachusetts that was so challenging, where health system was bought by private equity, really stripped of assets, and then there was a very sudden impact to patient access where there was risk of hospital closure very quickly. And I think that that was just alarming to me as a professional and just a person thinking about impacts of that. And I think I feel very grateful that, right now in our state, our hospitals, I have confidence, are focused on providing healthcare and their missions, but recognizing that there's this little bit of a trend, I think, nationally in the country of this shift where hospitals are being viewed as assets by these financial firms, and thinking about kind of protective action there. So I will say, admittedly, this is the one where maybe I kind of focused on one policy more than writ large here, and thinking about my assessment. But I wanted to capture that because that felt like a place where potentially there could be some, need for action, or where preemptive kind of action could be really helpful. And I will say, just in terms of alignment, again, it feels a little different, but it pulls the rug out of all the thinking about improving the healthcare system when there's, potentially this risk of such immediate and significant impacts to patients. So I thought about feasibility on this one. I think that I went back and forth on orange here because I do think that the legal landscape for trying to take action here is really complicated. And this is a new kind of frontier for states. I don't know that there's a clear, sort of model to follow. But that being said, I also think that, again, taking protective measures is a lot more feasible than trying to deal with fallout or deal with things sort of after there's been significant impact. So that's why I ended up rating it as green, is this felt like a place where potentially there could be some good agreement across a lot of stakeholders in terms of this being important, and something that folks could kind of rally around. And for opportunity, noted that generally in the space of provider market oversight, DHHS has some authority through the CON process currently, but, not maybe necessarily thinking about kind of new market dynamics and some of these changing, frontiers and addressing those. So that was what I tried to capture in this row. Again, note that it was a challenging one, but any thoughts or feedback there? Okay. So to move on to prescription drug affordability, the last one that I have on the list, I rated this one as green for alignment, both because I think there's acute affordability challenges for a segment of patients that are using some of the high cost drugs, and because I think folks are well aware in recent years, there's been some concerning trends and overall spending across payers. And I think with the kind of introduction or changing in use of GLP-1s and others, this is an area where I think folks have concern about contribution to total spending. That being said, I did rate the feasibility on this one as a red, and that comes from a perspective of, I think, just thinking about some of the bigger ideas in this state and sort of or in this area, and thinking about kind of the addressing root causes. It's really challenging, I think, for states to take action in this area, often because the multi-party sort of national supply chain makes addressing the price itself, or even oftentimes actors in the supply chain, really challenging. The other thing that I thought a bit about, somewhat unique to this policy domain, was just I do think in some of the other areas that other states are exploring, I mentioned the PBM regulation piece, that legislation has already been passed here in that area. And the one other thing I'll note is, I think that was back of mind for me, is just, I think, some conversation about in the lame duck session of Congress that there may be some action on both PBM regulation and potentially some of the aspects that Congress is uniquely positioned to deal with, like competition and sort of reforms to other pharmaceutical industry kind of business practices. So that's the one other thing, is I think there's at least a chance that maybe the national landscape on this issue kind of changes in the next 6 months or so. And then finally, for opportunity, noted here that the Bureau of Insurance has authority over that sort of new PBM oversight function. And also there is sort of the relationship to the Prescription Drug Affordability Board in terms of thinking about like where are the opportunities where the state can work, which is within the domain of the office, and that we support them with staffing, but also sort of happens separately, but is one additional reason why, the office is kind of engaging on these issues through staff support to that group, and complicates a little bit, not that we can't develop our own perspective, but just something to consider in terms of sort of the role of the office and adding additional capacity. I will pause there again to see if there were thoughts either on that one or maybe broader thoughts as a whole. Just noting, I think I saw Kevin agree with Katie as well on, the workforce concern. So we'll just note again that I'm happy to kind of take that one back and think through, a similar assessment of workforce, or can take comments there. I do hear it, and I think I just need to think more about what does that mean from a policy perspective, because it wasn't something that we kind of reviewed or discussed in as much depth before. Trevor?
Yeah, I would just say, I get why you've made this red, and getting at the actual price of these medications is going to be very difficult, if not impossible, for a state agency to do. But I do think there are some opportunities at the state level to reduce prescription drug costs in terms of making it easier for plan sponsors to be able to carve out pharmacy benefits and move away from some of the more egregious contract terms that exist in this space, which we see across our purchaser members who have done it, can lead to really significant savings, both at the plan sponsor level and at the member level. So I do think there is some opportunity to move the ball forward in this area, that can be done through the state.
Yeah. Agree there, and definitely didn't mean to imply, that there's no opportunity. Just that some of like the bigger ideas, especially the ones that I had summarized on the slide for this domain, that are sort of, the more transformative or direct consumer impacting ones, do have some challenging operational and legal factors to consider. I know we moved through fairly quickly, but appreciate additional feedback on this. As always, again, happy to get an email or to find time and connect with folks one-on-one if they digest this a little bit more and want to talk about some or all of the domains. I will say kind of my proposed next step from this is I'd like to take back the feedback, think on it a little bit more. Again, we'll add in some thinking on the workforce component, and then maybe come back, I think, with some additional ideas. And I had hoped to maybe move towards, I think, focusing in on a few of these areas, but I think with some of the feedback, just trying to decide if it's worth kind of having that conversation now, or if folks might need a little bit more time. Oh, sorry, I'll pause and think for a second. And I saw your hand is up, Jeff. Oh, Jeff, did you have a question or comment? Oh, there you go.
Yeah, you can go finish your thought and then just come back to me.
Oh, no worries. I was saying, I was like, I actually need a second to maybe finish formulating my thought. But what I was gonna propose, was just thinking about, in my initial kind of overview of this, I think constraining, or I should say realigning provider prices, the aligning incentives for efficiency, and the provider market oversight component were kind of the three that were rising to the top for me in terms of thinking about maybe building out some additional thinking on ideas, or kind of what could that mean in practice? What would that look like to bring back to the group for the next meeting? So wanted to see if folks had thoughts on that, or would kind of lobby for others to be included. Again, just want to acknowledge, like, I would love to work on all of these if I could. I do believe that there's promise in all of them, but again, in that effort to try to move towards, having a scope that's actionable and where we can focus and dig in a little bit more. That was my thinking.
Okay. So having, had a chance now to, go through the, the policy domains, and then sort of looping back to the three, areas of consideration: alignment, feasibility, and opportunity. As I think about these 6 domains, does it make sense to include, um, um, access as one of the areas to consider as we're thinking about these 6, right? So, and some of these, swing, different ways, right? So subsidizing consumer costs, that could certainly improve access. Um, you know, Constraining provider prices could have the opposite impact. Um, Aligning incentives for efficiency may again improve access. If and I'll go back to the primary care first model where the idea was to lift, a significant amount of the administrative burden off of providers and payers, which, again, part of the theory was that it would allow, providers to interact with patients in a convenient way as opposed to always having them have to come to the office or what have you. So, at least, as we think about this, I just wonder, if, access, ought to be, one of the items that goes across the top. I forget what they're called, but just my thought.
Yeah, it's a good point, Jeff. And I will admit that something that I struggled with and tried to do here was try not to get too far into like assessing all the pros and cons and impacts of the solutions within the domains, only because I do think that so much of that depends on detail. So it's hard, like we said when we were talking about ideas from other states, like, well, that might make sense with these caveats. So it was hard for me to your point to say like, yes, access would be improved by this until we get to the point of talking more about like an individual policy idea within one of the domains, if that makes sense. So I was trying to get more at just like generally, is this an area where we would have interest in doing something, and then we can do another round of analysis and that similar kind of assessment of impact, thinking about a policy idea within one of them. So I'm sorry if that's not fully answering your question. Definitely I'm open to the idea of adding access here, but I think that that would be the challenge in doing it is that gets into more of like an assessment of the um, effectiveness or the outcomes of the policy concept. But it may be that I can take that back and think more about it at a high level, because I think it's a great point in terms of that being an important
Value.
yeah, that value and something that we want to accomplish. But I guess if we were going to add access, I would then want to add affordability next to that, and then maybe we'd want efficiency. We could almost sort of like recreate the individual elements of the office's charge and the guiding principles and kind of assess. And I guess I just tried to kind of roll all of that up into that one first column. I'm wondering if that could be a good way of thinking about the next step. Oh, sorry, I'll pause. Katie, what did you want to say?
Sorry, I had a little crisis going on. So I missed the 3 that you were talking about. I think starting with out of the domains. I think I
Yep.
caught you saying that you were going to recommend 3.
Yeah, I was thinking about constraining prices, aligning incentives for efficiency, and provider market oversight as the 3 that I was kind of proposing. Though I think maybe from this conversation, I'm just trying to decide whether I can add sort of workforce and labor directly, or it may be worth doing the higher level of workforce and labor. But I just want to acknowledge again, hear that feedback, so it can definitely bring that back up for conversation.
Thank you.
Mhm. Anything else? That was the last slide that I have for today. So I will close out, and What I was going to propose for the next meeting was, like I said, I think a few agenda items actually that I've already mentioned. It'll be a lot maybe to get through, so potentially a shorter meeting this month, but we might make up for it at the next meeting. I think would like to do a summary of the public hearing and the comment that we received. Maybe we'll try and do that in a more concise way than last year, but definitely would like to kind of update the group and give everyone a readout from that. I'll briefly mention too, I think, an update on legislative reports. So definitely the facility fee report, coming back with kind of a next turn on that, and probably a preview of the annual report at the next meeting. But then from this conversation, thinking about coming back with kind of an expanded sense of, okay, within these 3 and maybe 4 domains, here are a set of at least high level kind of policy concepts that fit within them. Maybe in that sense, doing less of a menu and more of like a perspective of here's some things for us to actually talk about and consider whether the office should continue exploring them for potential recommendations. And can do some of that assessment, I think, that Jeff recommended, of think about, okay, we talked broadly about alignment with the office, but break out that alignment into access, affordability, quality, efficiency, and maybe kind of assess each of those ideas against those values or concepts. And then have, a bit of a more of a discussion from there about kind of policy ideas or direction. So that'd be my proposed agenda, I think, for that meeting. And I'll either incorporate in the workforce and labor piece there, or maybe that I bring that back at a higher level for some more discussion about what that could look like and what that could mean. Good. Wonderful. Oh, yeah, Katie.
Thank you, sorry. I guess I wonder, there is the affordability task force that's looking at prescription drugs as well.
Of the board?
The board, yes.
Mhm.
And I actually have never really followed it, but because that was one of the ideas that you had, a domain that you had as an opportunity, which I fully agree, it is a significant opportunity that's driving prices, not just for consumers directly, but indirectly through hospital prices as well. Is there an opportunity to sort of have them come present to us on what they're looking at and what they do?
Yeah, definitely. I think I'm happy to facilitate that. I will say the boards right now, the structure of that board is that they are tasked with looking specifically at public payers and making recommendations for spending targets and how to achieve the spending targets. In the time since I've come on board and been helping to staff the board, they've been talking about wanting to change their mandate and maybe, have more of an expansive kind of look at prescription drug costs more broadly. And so that's been where a lot of the conversation since I've been involved has been. And I think, there's a little bit at a crossroads in terms of which direction they're moving forward with. So that would be the only tricky thing, is right now that's a lot of the focus. But I think I'm happy to think about and have already sort of, I do try to keep both groups in mind when speaking to each one or helping to facilitate meetings for them. But I do really like that idea, and I would love at some point to bring the two together and, have a focused conversation or discussion. So I will give some more thought to that. I think that might be hard for the next meeting, but for a future meeting, definitely.
Thank you so much.
All right. Well, with that, thank you again all for adjusting and being willing to do this virtually. I definitely look forward to being in person with folks again for the December meeting. And with that, I think we can wrap up and give folks a little bit of time back on their Wednesday afternoon. But always wonderful to see you all and really appreciate all of the thoughtful feedback today. Have a good one.
Thank you so much.